जनगण मन अधिनायक जय हे भारत भाग्य विधाता। पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा। विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा। तव शुभ नामे जागे तव शुभ आशीष मागे। गाहे तव जय गाथा जनगण मंगलदायक जय हे भारत भाग्य विधाता। जय हे जय हे जय हे जय 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 हे।
Well, good evening, everyone, and welcome to the show. While the global tally around us will soon touch 3 million, India's cases have crossed 24,000. It's indeed a case to worry. Hardly any country across the globe is left untouched with COVID, even a bigger worry. While on the one hand, it has exposed chinks in the healthcare systems worldwide, however well prepared you might be, on the other, it is also opening up newer opportunities for the healthcare sector. A lot of innovation has set in motion. We, during the last 4 weeks, organized a number of online consultations with doctors to discuss and deliberate on the issues, including research, response, and the role technology could play in view of the COVID-19 outbreak. Believe me, it's been an eye-opener that encouraged us to put together this seminar. Today we have with us practitioners, experts, healthcare professionals, policymakers, and researchers from across the world. Frankly speaking, these are the people expected to deliver to people's expectations under today's circumstances. We call them doctors against COVID. To talk about India, one of the biggest challenge is in providing the treatment to the patients, and that is the non-availability of medical history. There is hardly any medical history, that is true, but also a complete absence of medical records in addition. This has come in as a major stumbling block. Like the way you have know your customer norms for the banking system in India, what is needed is also under the current pandemic situation is know your patient, and more importantly, access to his medical history. It is indeed a felt need today. While technology has come to the rescue, arguments regarding confidentiality and privacy hampering have also come along. I'm sure all of you will agree that there is a difference between COVID and an infection like HIV. Singapore calls it Trace Together, UAE Trace COVID, UK NHS app Australia, Coronavirus Australia, several such examples worldwide. We call it Aarogya Setu. It is being seen as a potential tool in the hands of doctors and medical practitioners to better fight this battle against COVID. So, what are we going to be discussing today? A, role of apps in epidemic control used by several countries. B, what has been India's response and learnings overall to COVID? C, what is the situation globally? And D, where are we on the vaccine? Our first speaker in today's discussion is Dr. Rakesh Kumar, Chief Advisor, UNDP India. I would like to invite him to talk about India's response. Dr. Kumar. Kunal, can you unmute him, please?
So let me thank you, Dr. Gursharan and Sameerji for hosting this very important webinar around COVID. And as you initially mentioned, and very rightly so also, it's a pandemic of a different nature, different kind. You would recall that, Wuhan a city in Hubei province of China reported 44 cases of pneumonia, to WHO on 31st of December 2019. And this virus, this virus was supposed to be of different nature, like it was different from SARS, though it belongs to the same family, but different from SARS or MERS or influenza or avian flu. So that's why, the name has been given differently. COVID, why we call it is COVID? Simply because COVID, like CO is corona, VI is virus, D is disease. And 19 is basically because the virus was detected in 2019 on 31st December 2019. When you look at the global picture, it's very horrifying. Close to 3 million cases, positive cases, close to 200,000 deaths. Look at where exactly US is today, 50,000 plus deaths. And look at Europe, more than 100,000 deaths. Look at UK, it's close to, again, more than 20,000 deaths. India, though, has done tremendously well, I would like to mention here. But, as yesterday I was reading some article and somebody mentioned it very rightly, said, look, it's like a third world war where all the nations are together fighting against this virus. So I think the best part is that the whole world is together to fight against this coronavirus. When we talk about India's response and India, for multiple reasons, because when we talk about India, we don't have that kind of robust health systems what Europe, UK or US will have, Our immunity levels are also not very high. We have high levels of malnutrition. And, when we talk about this disease, the dynamics of disease is not different, in other countries. So thereby, I think it becomes all the more important for us, India, to save us. But let me just speak at the outset and say that India has done tremendously well so far. And so far means till date, I can easily talk about this. And India adopted a three-pronged strategy, a four-pronged strategy. The first thing was that a single, simple, honest communication, coming right from the topmost people, right from the Honorable Prime Minister. Look at the kind of coordinated efforts which are being done, by the Ministries of Home and Health and all the departments. I think the single line of communication is really making a difference. So that's a very coordinated, single, honest, and straight communication going to the states. I think that's the first, I would like to say, very strong point. The second strong point, obviously, is all about, we talk about social distancing, distance of maintaining 1.5 meters to 2 meters. And lockdown has certainly worked very well. And I'll speak a bit about this. So it's more than now 30 days we are at a lockdown. And how it is really helped, I think I'll talk a bit later about this. The third, of course, is, aggressive contact tracing, identification of the cases, and then quarantining them, then isolating them, and ultimately the treatment part. So I think these are the three important, I would say, principles which India has really followed so far. And mostly they are around the prevention. I think the first point which I want to make very strongly is that India has worked very well on the prevention side. Now, how this lockdown has really worked so far, I think that's very important for us to understand. Firstly, I think we have been able to ramp up our testing. When the lockdown was started, let us say we talk about 23rd of March, our testing was close to 14,000. Now, till yesterday, it is 500,000. So I think we have been able to do more and more testing and talking about antigen testing. But still, I think even 500,000 is too less and more needs to be done. And the second part is that, it also talks about, how we have been able to cut down in the transmission of, look at the numbers, US at 5 million, 500,000 of testing, it was close to 80,000, cases. UK at 500,000 testing, the number of cases were 1.2 lakhs. Similarly, Italy, more than 80,000. But in India at 500,000 testing or 500,000, we are close to 25,000. I think that is the kind. So certainly, I think we have been able to cut down the transmission. So the first part. The second part is that look at the test. We used to have close to 75 labs when we started. Currently, we have 325 labs across the country. And I said that's because of these reasons we have been able to ramp up the testing. And the third important part is that our effort, all-out effort, is that we don't get more cases so that we don't need hospitalization. That's why there's a more focus on the prevention side. But I think the whole preparedness is focused at the district level. So there are three layered kind of facilities which have been created at the district level. We are talking about Corona Care Center, where, it's basically isolating, Corona positive cases or otherwise the contacts. Second level is where we have the oxygen availability, and third level is basically when we're talking about the hospital, ICU facilities or ventilators are there. So as on date, if I look at the numbers, so we have close to 200,000, sort of isolation beds available, at different levels. We have more than 25,000 ICU facilities across the country. What I'm trying to say that this lockdown period has allowed us to ramp up our health systems across the country, so that, we are not really caught unaware. So I think this lockdown has worked tremendously well. We have been able to prepare ourselves, but I'll just end by saying one thing, as I said, the dynamics of the disease are no different than what we see in USA or Europe or UK. That's why I think we need to be prepared for the worst. And worst means, as on date, I think absolutely we have done wonders, but I think future, we can't really say. So I'll stop short here, Dr. Dhanjal, at this point of time, and then obviously I'll come later.
Sure. Thank you so much for sharing your ideas with us. We are going to be soon joined by Mr. Arnab Kumar from NITI Aayog. But in between, let me move over to Dr. Vidur Jyoti. He's Associate Director and Head of Department of General and Minimal Access Surgery at Max Hospital. He's giving his perspective on doctors and Aarogya Setu. Dr. Jyoti.
Good evening, Dr. Gursharan and everyone in this seminar. Doctors and Aarogya Setu. See, as doctors, we are already dealing with Aarogya. So how about the Setu? What Setu is this? This is a bridge between public and the professionals. Now, talking of Aarogya Setu as an app, which has come up now in the wake of contact tracing when we are confronting this Corona SKOCH. So I'll just give you a little perspective of what all is available by way of contact tracings in globally in 23 countries. We already have 43 such apps. 28% of them have no privacy controls, and 64% of them are based on GPS. India alone has 16 apps. Before Aarogya Setu was introduced, and that too in a big way by the Prime Minister himself. Some states had already embarked on this community and surveillance and contact tracing. Now, in the control of infections, we already have instances like meningitis, SARS, H1N1 influenza in 2009, and the STDs, where the contact tracing is already being used. So as a technology or as a technique, contact tracing is nothing new. But in the perspective of the current issue, such a pandemic of a disease, which is such a big killer all over the world, this becomes all the more relevant that we have access to this technology as medical professionals. And then we make a bridge with the public. So this reminds me of Sir Douglas Black, who is credited with the development of NHS in Britain and was Emeritus Professor of Medicine at Manchester. And I quote him, "Main determinants of health and disease lie outside the realm of direct medical competency," unquote. So what is this realm of direct, what is outside the realm? Outside the realm is the realm of health IT and medical records. In India, we are all, as medical professionals, well aware of the pathetic state of health records that we have. Less than 5% of data collected in India is medical record data. Only 400 out of 62,000 hospitals, they collect data on patients. This inadequate data and more of an incorrect data leads to improper planning. There is a lack of the deficiency on the part of doctors as well. We don't participate wholeheartedly in data generation. So this Aarogya Setu should prove as a blessing in disguise for medical profession. As doctors, we should be able to generate more data on disease and the disease management. So this is important because community surveillance is the only weapon available for managing infectious and communicable diseases. Although non-communicable diseases are taking a great toll these days in India, but communicable diseases is all for you to see for yourself. We are facing this virus. We are already facing tuberculosis. We are already facing leprosy to a great extent. We have been able to eradicate smallpox, polio. But how was polio eradicated? It was only eradicated by the very, very extensive application of contact tracing and surveillance. So surveillance and contact tracing through Aarogya Setu should be the backbone of the policy making as far as medical scenario in India is concerned. And Aarogya Setu, I believe, as a doctor and as a citizen, is going to be of use for all of us. Now, I'll just take you to a bit of the digital health technology scene outside India. See, health, IT, and EHR interoperability has to be ensured. I'm sure that this pandemic of the century will come to an end sooner than later. Medical fraternity, despite being the frontline warriors now, we are already seized with the challenges of the new normal. This new normal is going to emerge after this scourge the disease has been dealt with effectively. Now, what this new normal will be, we will have to have a blueprint on the roadmap of healthcare delivery. Now, we must distinguish what is healthcare delivery and what is medical care delivery. More often than not, we mix the two things. As healthcare delivery is a very, very comprehensive umbrella term, of which medical delivery forms only a small part. When we're talking of health of a nation or a society, we must know that it depends upon environmental factors, nutrition, and control over communicable diseases that take a lot of toll. So, Aarogya Setu, when it's being used as the electronic medical records, is going to be of use for doctors as well as healthcare planners. The global health crisis by this virus has brought forth some universal inadequacies of systems, ranging from inadequate infrastructure, imbalance in availability of medical technology, suboptimal resource, and lack of coordination in health and other wings of civil administration. Aarogya Setu, I believe, is going to be of use to overcome all this. So we have learned that the WHO is often changing its stance, whereas in India, ICMR and our own scientists have strengthened and improvised the system. Even though at the moment we don't have that kind of data, but Aarogya Setu is such a popular application that within the first 2 weeks of its announcement, we already had 50 million users. So, again, I would stress that as doctors and as medical policy makers, we must continue this. This Aarogya Setu should be a permanent Setu between public and professionals. We should aim at meeting the other challenges like dengue, hemorrhagic fever, tuberculosis, HIV/AIDS, malaria, all this plus immunity boosting. We are talking about immunity boosting extensively these days in the context of the coronavirus as well. So once we have a data on the public, then we can have integration of the systems. We are lucky that in India, we have so much of medical help available in the form of allopathic and traditional medicine, non-allopathic treatment. So once we have data, I believe, generated through Aarogya Setu, we can integrate all this, Ayush and allopathy. Allopathy, Ayush should not be seen as competitors.
Dr. Jyoti, I'll interrupt you here. I guess there would be another opportunity to bring in the alternate perspective on Aarogya Setu. In between, let me move over to inviting Mr. Arnab Kumar from NITI Aayog. He has joined us. He will be talking about the aspects of Aarogya Setu app itself, since NITI Aayog is the one which is spearheading it. Mr. Arnab.
Thank you, Dr. Gursharan. Thank you very much, everyone, for dialing into this conversation and allowing us all a chance to have an informed conversation in Aarogya Setu. when we were developing Aarogya Setu, when we started doing this 6 weeks ago, the primary purpose of what we did was to make sure that we buy more time to our frontline health workers. We develop a comprehensive solution backed by technology that can help us understand how the infection is moving, what is the direction and velocity, and whether we can automate some of the processes that are involved right now in terms of tracing who may all have become infected when somebody turns COVID-19 positive. Contact tracing is the central theme, central spirit of the product, which is what we are doing through Bluetooth. What we have also done is that made sure that we take care of all the aspects of the app from a medical perspective. So if you see a self-assessment tool, it's as per the ICMR approved guideline, we have a strong dependency and connect with ICMR. What we have also done is that in our backends are integrated with both ICMR dataset and the NCDC dataset, so that we make sure that there's a real-time communication between the two, and the app starts triggering for contact tracing the moment somebody turns COVID-19 positive. The app works in a very simple way, which is when if two people with the app installed have their Bluetooth on, we take a signature of the two interactions, store it on the device, and only pull this information in case one of us turned COVID-19 positive, in which case we look at the contacts made by this person in the last 14 days. We then calculate the risk of infection. What we do not do is just to create a table of who all they have come in contact with. We go a step further and say, what could be the potential risk of infection of this person having met a COVID-19 positive person? And then we categorize that risk and take appropriate medical action. This could range from testing that person versus putting them in quarantine versus advising them self-isolation. What we have done is, and we have made it very clear that this is not a definitive indication of you turning COVID-19 positive. This is a probability of infection, and hence, if we have to be targeted about our testing protocol, we have to be targeted about where and how hotspots are emerging. That is what we are doing. Two things that we have made absolute care of is that a lot of people are trusting their sensitive information with us. So we do to the best of our ability not to make sure that the data is compromised at any stage. And the second aspect is that the app is so intuitive and easy to use that it's in the hand of every single Indian in the country, which is the manifestation of that is that you will see that the app is currently in 12 languages. We intend to extend this to all 22 scheduled languages of the country. What we also introduce is that you'll see that most of the information on the app itself is large font graphics rather than small texts. And the second thing is that we have a very sophisticated dashboard at the back end, which is working with doctors, etc., in real time. Basis the self-assessment test that people have filled across the country, we have highlighted a number of people who may be at risk because of various symptoms that we have shown may or may not be related to COVID-19. What we have done is that we have asked Ayushman Bharat, and with a set of army of doctors, we are proactively reaching out to the people who may be at risk for various things. So if somebody has said cough as a symptom, can we reach out to them and say whether they're doing okay or not? They've already started doing it, and our plan is to cover every single one of us in the limited period of time to make sure that everybody is happy, everybody is safe in these difficult times. So this is what we are trying to do: gather information, act on them proactively, design our testing and medical intervention strategy as a country, while making sure that the data is safe. Data is only exposed to people who are directly related to COVID-19 medical intervention. Nobody who is not needed to know about the information can ever have access to this data. That is a promise that we have to the citizens of the country as a design principle for that. Thank you.
Thank you. I would like now to move on to something very important, which Dr. Anuj Chawla is going to be talking about. He's a consultant orthopedics at Birla Hospital on making Aarogya Setu mandatory. So it's a double-edged sword, yes and no, both. Over to you.
Thank you very much, Dr. Gursharan. I'm really glad to be a part of the 64th SKOCH Summit. Yes, as you mentioned, I'm an orthopedic surgeon. I am not the one at the moment, at least, who is posted in a COVID ward. So I think I would be just talking about my perspective as a healthcare personnel. So when I go to the hospital and I see the patient, I need to know whether that patient has any travel history or any suspicion signs of COVID, so that I'm not denying the patient, but at least I can manage the patient and I can prepare myself, and not just myself, but every healthcare staff, who's working in the hospital can prepare themselves even at this point of time. So I think the best way, I mean, we can't do coronavirus test for every patient who enters the hospital. And I think it is a very simple way. I mean, if Aarogya Setu app delivers what it is supposed to deliver, and if everyone has it, at least those patients who are orange or red, it would be notified. Then we would be prepared. And I'm not saying just in the hospital, but probably outside the hospital and in community as well. But well, let me give you one example, which actually I read, I think last week. It was one of the government hospitals in Delhi, in which there was a patient who was a pregnant lady who came to the hospital with some complication. She underwent a surgery. She was transferred to the ICU. But all this while, she never disclosed her travel history. She never disclosed that she has been actually been quarantined for being suspected of coronavirus. Eventually, they did a test for her, and she turned out to be positive. Well, as a result of that, I think 68 medics were actually quarantined. And that hospital, you just imagine in a busy government hospital, I mean, if there are 68 healthcare workers who are quarantined, well, we are actually working with almost half the efficiency of the hospital. So I think in that sense, had that patient not told the history of being positive, had she just underwent a uncomplicated minor surgery, has been in contact with 68 people, gone back home without even informing her status, well, it would have been even more dangerous. Because in that circumstances, I mean, a domino effect would have arisen. All those 68 people would have seen a lot more patients, which has actually happened in a lot of parts as well. And some of them might have been asymptomatic, but definitely they would have transmitted the virus had they turned out to be positive. So I think at this point of time, it is very important for us to be aware, to know who are the contacts, and especially when we're talking about opening the lockdown, when we are lifting all the barricades and when the hospital would start flooding again with the patients, we should be very cautious about who we are seeing in what circumstances. We would not have PPE for every patient. We don't really want all the patients to be sitting together. I mean, when I am sitting in my clinic, for example, and I have a small, for example, I just have like a 200 square feet waiting area. I need to maintain social distancing. And if some such patient comes who actually would be suspected of having coronavirus and does not have the app, I don't know the status. The patient turns up and infects everyone in the clinic, as well as infects me, and I infect every other person that I see. I actually feel jolted to think about that happening, and it has actually happened.
In fact, this is something which is what you're talking about. I would
Yeah.
say, quote unquote, a felt need, because at the end of the day, one needs to know as to who's infected and under what circumstances. And because
right.
you are at the other end, because one person going scot-free is going to add only zeros to it. 10 will become
That's
100
right.
and 100 will become
That's
1,000.
right.
So moving over to Dr. Sarita Agarwal, she's a senior medical practitioner. And what does a doctor need from Aarogya Setu? What is it that your expectation is, and what is it that an app like this could do to a doctor? Dr. Agarwal.
Good evening, everyone. I'm thankful to SKOCH for making me part of this initiative, which aims to fight COVID-19. Now, as a medical practitioner, we have two sides of picture to look at. One, we have moral responsibilities towards the citizens who are looking towards, and other side, we have equal responsibilities towards our families and health co-workers. So we are highly thankful to Government of India for making a great Aarogya Setu app in a very short period of time, which gives us insight of the patient. Now, as a medical practitioner, we can get benefit from this app only if we can get the maximum benefit if we have access to this app. Now in current pandemic situation, the call is like, you save me, I save you. We need to first save ourselves to save our patients. So if patient comes to us, we need to know the current situation of the patient, like what are the chances that patient might have COVID plus. So through this app, we can know the zone of the patient, in like whether he is in red zone, orange zone. So we can treat patient accordingly. Secondly, when we are going to hospitals, like as far as privacy is concerned, when we are putting our lives at risk, when we are going to hospital, we we can assure our patient we will never use this app, like we will never invade into your privacy. We will use it only for the benefit of our patient. And it's just a suggestion that we can link this app to Aadhaar card or any other unique ID number, so that medical history of two patients will not mix match. And as already mentioned by Dr. Vidur sir, it can be made a national health portal of India, where we can start putting medical history of the patient, so that in case of any emergency, we know the drug allergy, we know the medical history of the patient. Now, how to motivate the patient? Now, how to motivate the citizens to download this app? We can start using teleconsultation through this app. As in current pandemic situation, many people doesn't want to visit to the hospital, and a gap has created in between doctors and patients. Like for routine examination, patient doesn't want to go to the hospital. So through this app, we can fill that gap. Secondly, we can link this app with Ayushman Bharat or any other health insurance agency to make it an end-to-end portal. So a patient can directly claim their insurance through it. And as already mentioned by Dr. Anuj Chawla, I also agree to him. Like this app should be made mandatory, and as mentioned by Dr. Vidur sir, it should be made a national health portal of India. Thank you.
Thank you so much. So thanks for the feedback on whether the app is to be made mandatory and what good that it can do to the medical practitioners. At this moment, we can take a couple of questions if there are. Arnab will be joining us in about 10 minutes, so we can save questions for him. But otherwise, if there are any, we can take, or else we can move on to the next. So you can raise your hand for the questions, or we go on to the next.
I would
Fair
like
enough. Mr. Madan Mohan, please go ahead.
See, personally speaking, I have discussed with a number of people with regard to the utility of this app. And the feedback which I got from them was that suppose the person is not correctly disclosing his things in the app. So how do you really rate him, whether it's an orange or a green or whatever it is? So the correct information availability is a big issue. That's how they say there is no use. We are not sure whether the person, he may be positive, but he has not disclosed it in his app. So this is one thing which needs to be cleared. Another thing is with regard to privacy. Obviously, there are many people who are raising hue and cry about this, that how this is going to be resolved. Especially, suppose after this is over, how do we ensure that this data will not be used for anything else?
So you have this poll coming up on your screens. Kindly do participate in this. This is going to be extremely helpful to capture as to what is it that each and every participant and panelist thinks about the app. Mr. Madhamohan, your question is pointed at whom?
No, this is pointed at Dr. Chawla.
All right. So I think you have very well explained. So we'll move over to Dr. Chawla to kindly answer Mr. Madan Mohan.
Sorry, I think this was discussed before only, that I think in the previous forum, that what if the patient does not disclose his own identity. Now, as it was mentioned before, that the data that we're talking about, I mean, I'm assuming that the patient would actually not disclose his identity, and specifically with regards to the past medical history. I don't think at this point of time the app is equipped enough, but because we have an integration with the ICMR, which would tell whether the patient is COVID positive, as well as NCDC, which would help us in finding that the patient has come in contact or probably is in quarantine. So I think in that sense, the patient would not have control to manage these things. This is what my understanding of this app it, and I'm sure Arnab can detail on it in a better manner. So I think despite everything, we would still be able to siphon out who are at-risk candidates.
Thank you. Any other questions or? Well,
I
so
can
this-
can I come in
Yeah.
at yeah. So my question is, what is the necessity of having confidential personal information for Aarogya Setu? I would see Aarogya Setu as a infectious disease surveillance mechanism and contact tracing and tracking. So if we make it simplified, and basically to begin with, we are talking about COVID. Later on, it can become for many other similar infectious disease, including measles and rubella and polio, etc. So I would like the Arnab as well as Dr. Vidur, what is their viewpoint to make it simplified and use it primarily as a surveillance and tracking mechanism?
We will take Dr. Vidur at this moment. Arnab, we will ask him to respond to this the moment he comes back.
This is a good
Dr. please
point,
go ahead.
Professor Arora, and also I later on want to reply to Mr. Mohan as well. As far as the ambit of its scope is concerned, it is definitely a good application and should be this ambit. It should be expanded to include comprehensive health data on the citizens of India. It is just not infectious control. Infectious, yes, surveillance and contact tracing is good for infectious controls, but once we link this with the electronic medical record or electronic health records being generated from the hospitals, from the clinics. See, the India scenario has been digitalized in a big way. We have Jan Dhan Yojana, Pradhan Mantri Krishi Insurance Bima Yojana, so many plans which are digital. So this health, we already have a national health portal, but medical records are a big deficiency. So I would agree that it cannot be just a responsibility of a patient or of an individual to give the data. Like in Corona, this Aarogya Setu with respect to Corona, this responsibility lies with the user to tell the contact history, the travel history, cough, fever, this, that. But for the future, we talk, like Professor Arora talked about measles and other diseases, we will depend upon the medical practitioners in the hospitals to fill in the data. And it's a good idea to link it with unique IDs like Aadhaar, so that no medical fact escapes the attention of a medical professional. Eventually, it's going to be good for the citizens, no one else.
Thank you so much. We have another hand going up. Kunal, can you unmute Mr. Subodh Shukla, please? Mr. Shukla, please go ahead. And to whom your question is pointed?
Good evening. I'll make one observation and maybe one question for anyone to answer.
You have a minute.
Yeah, the observation is that there is no escape from this kind of data collection now. So whoever is collecting the data, they need to be made accountable. That is all. But the data needs to be collected, and because that is the only way we can try and control this situation. So if there is a need to make the custodians of the data accountable, someone needs to think about it, so that they also feel that they're responsible and they don't do things which can jeopardize the data. The question which I have is, this app runs on smartphones, that is my understanding. But in India, a lot of people don't use smartphones yet. So what do we do about them?
So answer to that is very simple. We'll have to wait for Arnab to come back. So I can see.
I can help.
Yes, please go ahead.
This question was answered in the last session. So there is a feature phone version in the offing. It's coming soon.
Okay.
It may work without a smartphone as well.
May I add here that this is no not directly related to the observation. I would quote Sir Winston Churchill. He says, "Never let a good crisis go waste," unquote. So this is a crisis, and Aarogya Setu looks at it is a proverbial silver lining in a black cloud. So with the kind of IT prowess that the nation has at the moment, and the medical acumen, they should be integrated so that the people to professional bridge remains steady and strong.
Thank you. I guess we'll come back to Mr. Aruna Huja in a while. We'll, in the meanwhile, go over to Professor N.K. Arora, Chairman INCLEN India, on WHO's response. So you have 3 minutes.
Okay, so I am going on a very different way, and I'll present 3 slides. And so I will just take you through the various milestones during last 10 weeks or no, last 14 weeks or so, what has been happening at global level, because there has been a lot of talk about WHO not responding in time. So I will take you through the various milestones. So the first time on 31st December, China informed WHO, and they had the first case of corona was on 8 December in Wuhan, and China informed that on 31st, and on 1st January, WHO had a incident management support team working and trying to work out for country emergency plan for outbreak. On 5th January, WHO notified first disease outbreak and issues related risk assessment, status of patients, and public health response by China. This was 5th. 10th January. 10th January, first cases outside China started coming and reported. So cases were in Thailand, South Korea, Japan, Singapore, and gene sequence was also released at this time. 10 days later, on 20th and 21st January, WHO team visits China, and at that time, China releases the basic material and knowledge about how to do these tests. These are called primers and probes for the current RT-PCR test, which is done. But that information came up for the first time. And this is the time when first case occurred in USA. On 23rd, immediately after this field visit, WHO Executive Committee meeting headed by DG WHO, but there was no consensus to declare it a public health emergency of international concern. And immediately after this, 5 days later, DG himself visits China to discuss with the leadership. So there is concern, but there is the executive committee could not come to a decision, and DG was asked to visit China. On 30th January, now executive committee has a second meeting, and they declare COVID as a public health emergency of international concerns. And so they start preparing in February strategic preparedness and response plan. But during February, most of the February, they were working mostly on research priorities. There was issues about supplies and kits for PPE and training of envoys.
The poll is back on the screen once again. Kindly do participate. Professor, please carry on.
Sir. And there was a blueprint of R&D was developed. It is only on 11th March that WHO declared COVID-19 as a pandemic. So most of the February was more talking about research issues. And although they on 30th January, they had declared this as a public health emergency of international concern. And then by 15th March, they started doing these surveillance studies and the various kind of studies.
Professor Arora, sorry to interrupt. You have a minute.
Yes, it is. This is my last slide. And on 20th March, where our Honorable Prime Minister was also there, G20 had an extraordinary G20 summit on COVID-19. And so all this while was happening, by 8th or 9th, 1 million cases had occurred and 100,000 deaths had occurred. We see within next 5-6 days, the number of global cases have doubled to 2 million. And now on 25th of April, we have 3 million cases and almost 200,000 cases, as Rakesh was saying. A struggle goes on. But these were the major milestones and how the world has been moving in this direction. So I will stop at that. At the global level, what was happening. There was certainly in the month of February, which was a very important period, nothing substantial was done in terms of warning the nations and countries about this. Thank you very much.
Thank you. So this brings us to the Indian perspective from the WHO one. I invite Dr. Parveen Bhatia, who is Medical Director at Bhatia Global Hospital and a Senior Surgeon at Sir Ganga Hospital. Over to you, sir.
Thank you very much. In God we trust, all others must bring data. And I am going to have 3 minutes and 3 thoughts. One is impact of lockdown, testing, tracing, and you have seen that we are bending the curve or not. It, as compared to United States and other countries, definitely the answer is yes, we are bending the curve. In last 1 month of lockdown, the infection rate, if you can see, when the lockdown was clamped on March 25th, the infection rate doubled to in 3.1 days. And now the infection is doubling in 8.6 days. Similarly, deaths from 4 days initially when the lockdown was started, and now it takes for the doubling to be in 11 days. And how have we fared vis-a-vis the world? If we start from first case to the 80th day, you can see the Indian numbers. Numbers have definitely been less of both cases as well as deaths because of the lockdown. It has a lot of impact. The mortality rate has also been restricted to 3.2% vis-a-vis in comparison with UK, Spain, Italy, which are hovering between 13 and 10%. Why? Because we are very, very sure that we want to flatten the curve. As our Prime Minister had also requested that religiously lockdown has to be observed. If, for example, if the number of cases rise suddenly, if the lockdown is broken in few days, then the healthcare facility may not be resources may not be as adequate as it should have been. And that will cause another spike, another wave, and that can lead to different disasters. So thinking is, yes, we should control it. And I would give this Lancet presentation, which has been published just today. And it is the journal, all of us know, it has the maximum impact factor. They have complimented India for the tough and timely action of putting the lockdown. Why India has been favored is because of 65% of our population is less than 35 years, though they have condemned that the rate of testing has been very low and it has to be expanded exponentially. Thanks to ICMR, initially on March 24th, 25th, only 2,000 tests were performed, but now we are performing 41,000 tests every day. And that is the reason that we have been able to control, to make the different zones, and then discard and ultimately treat the patients. Our thinking is, all of us have been hearing from the morning that this Aarogya Setu is definitely an excellent thought, and it was announced by Prime Minister also. This is my last slide in which I am going to present a few words that it is good to note that 75 million downloads have been there. And in last, if the telephone was there, it took 75 years. The radio took 38 years. Internet took 4 years. Facebook took 19 months. And Aarogya Setu has been downloaded by 50 million people in just 13 days. If it is popular, if it is useful, and another aspect is that once we are on the verge of breaking or withdrawing the lockdown, then only it is going to make a difference. So our thoughts are that as a doctor, as a surgeon, I would request you all that stay home, stay safe. God bless us all. We are in a positive situation. We will be able to show the world and WHO and every other country that yes, we had excellent leadership and we have been able to control because of IT also. Thank you very much. Thanks a lot.
Thank you, Dr. Bhatia, for presenting the Indian perspective on COVID. And as you say that we have shown to the world, we have shown to the WHO. And as much as we have Professor Ashish Joshi from Graduate School of Public Health and Health Policy, City University of New York, talking about the rapid tracker and the US experience. Over to you.
Yeah. Thank you so much, Dr. Gursharan. I hope you can see my screen.
Yes, please go ahead.
Okay. Thank you for giving me this opportunity. And I'll be a little bit quick because I know I have a limited time, but I just wanted to make sure that I'm able to present a perspective. I'm not going to go through because everybody has talked that there are about more than 2.6 million cases now and about expansion in 213 countries. As a US at a glance as of yesterday, we had about 800,000 cases with 46,000 deaths. And it's almost everywhere in the United States, about 55 jurisdictions. That reflects to you the importance of how it is critical to have such a timely intervention. Very quickly, the number of cases in COVID, I am putting up in New Jersey, and I work with the City University of New York as a senior associate dean. New York and New Jersey have been impacted the most. We are at the epicenter of this epidemic. And if you look at some of the states which are contributing to overall US deaths, about more than 50% of the deaths which have happened in the US have been attributed to only two states, New York and New Jersey. There are top 12 states. It's very important when we are talking about the data. It's also very important to look at the rates and not just the cases, because the rate is able to tell us based on our denominator of the population. Shows New York and New Jersey and Massachusetts are the three top states which have the highest rates of COVID-19. As we are talking about in New York City, my presentation would go incomplete if I don't talk briefly about New York City. I would say that there have been confirmed death cases of about 10,000 people within the city of New York. And interestingly, if you look at this graph, I wanted to make sure that this is important, that we are starting to see the flattening of the curve in New York City, even though that there is taken a lot more time. Hospitalizations have started to go down and the number of deaths are starting to go down. But very important part which one has to talk about is what is the point when we open the lockdown? The milestones, there are three milestones which New York City has come up with. One, they want to make sure that for the 10 consecutive days, there are less than 200 hospital admissions. And this is for the first time on April 22nd that they had 173. So we need to wait for 10 more days before we start to exit out of our social isolation. The second very important milestone was on critical care. The requirement is that we are going to have less than 375 people in 10 consecutive days to make sure that our strategy is working. We are at 786 as of now. Lastly, the testing, which everybody is emphasizing. The goal is here that we need to make sure that the public health laboratories which are testing, there are fewer than 30% people to be tested, and 15% New York City resident tested on the New York City labs. Now, we are way far away from this number, and currently we stand at about 50%. That means, yes, we are moving towards the right direction, but it might be taking a little bit more long. Just a quick, I know I have a minute I want to produce. This is our attempt to put the rapid tracker. Very importantly, how this visualization platform is different from others is that it is a policy informatics tool, which means we are integrating the data with the non-pharmaceutical interventions like social distancing and other factors to see how they are influencing the burden of the disease and its spread. So this is the uniqueness of the platform. Very importantly, we are looking both at the level of the various countries as well as from the case data which is being presented from the COVID-19. The advantages of having this comparative model of different countries is because every country is at its different stage. So we can actually see whether what interventions have been working for different countries in the similar platform. Very quickly, I will show that because this is what I want to show on the Indian context, what we've done. We've been starting to map the curve. We've been starting to map the cases, and we're starting to look at different advisories which were being put up in place and the impact of those advisories and policy actions which is happening. I'm very excited to share here that we are more than happy to put together an expert panel group of like esteemed people who are here and seek their input to make this platform more robust so that this solves not only, this is my commitment and our team commitment from here in whatever we can do to this kind of a global crisis at this point. Lastly, I want to thank our Rapid Tracker project team. Each one of them has worked very diligently. These are young public health professionals in India. They are working day and night, even from their home settings, to show how important we can do this as a collective way. Thank you, SKOCH group, for the invite. And I look forward for people to look at this tracker and to make it much more robust and see how we can collectively take a responsibility. It's not about we sitting in the US. I know that we are in the middle of this epidemic, and I commend India for its efforts. There's no question the lockdown is phenomenal. They did very right and timely intervention. And lastly, I would say that Aarogya Setu is really something to be watched, and it will be helpful to see how more data comes out of that. Thank you very much, and thank you for this opportunity.
Thank you, Professor. We'll quickly ask Mr. Ahuja to take his question because he's been waiting patiently for a very long time. So, Mr. Ahuja, can you go ahead, please? Kunal, can you unmute him?
Myself, C. Arun Ahuja. This is not a query, but one suggestion that Aarogya Setu application can only be and should be made mandatory only after passing the forensic system audit and ethical hacking tools. Otherwise, it can be a self-vote.
Thank you. In fact, while the big things about Corona are being discussed, some very basic questions are being put up by one of our attendee. There's this gentleman called Karan Jasuja. He's asking that view of Corona pandemic, we understand, a whole lot of precautions that we need to take. What's your advice on washing vegetables and fruits? Is that enough? So Dr. Bhatia, would you like to answer this?
Sure, definitely. And as you didn't know that last time also when we had webinar, similar kind of simple questions were asked. Our thoughts are that if you are getting the vegetables from outside, definitely it needs thorough rinsing with running water. Running water should be used. And then as all of us know, and we have been emphasizing that hands should be washed before and after for 20 seconds. 20 seconds is not a small time, and one should make sure that we are washing the hands on both the surfaces, this side, and then we are going into the web also. When somebody delivers, please make sure that he is maintaining a social distance. It should never be that he is handing over, or he is handing over to somebody, and then we are using the vegetables or the milk packets. So our thinking is that we should request them. The vendor should put the vegetables outside. After some time, once he leaves, then we should pick it up, thoroughly rinse it, do your hand washing properly, maintain a good social distance, and then definitely it will make us literally safe.
Thank you. There is one question that has come online, that there must be data protection law in place before taking such steps. Law should be very transparent and inspired from GDPR. So
I will like to answer this question.
Please go ahead.
Yeah, so there is a new law which is lying in before the parliamentary committee, which is called Disha, and it talks about the confidentiality of personal data, and there are stringent laws coming up. So it is just a matter of time, but for practical purposes, this has become the benchmark as far as protection of personal sensitive data. And it compares with international similar laws elsewhere, including European, which you just mentioned, GPRS.
Thank you. At this moment, let me invite Dr. Collins Iwuji. He's consultant and sexual health and HIV medicine from University of Sussex, that's UK, and adjunct faculty at Africa Health Research Institute, South Africa. I would like to, invite him to speak about virus and epidemiology and spread of virus. So this is one perspective which is going to be totally different from the rest. Dr. Collins, can you hear me?
Can you hear me?
Yes, please go ahead.
Yeah, thank you very much for inviting me to this webinar. It's very well appreciated. I've been asked to talk about coronavirus spread and the epidemiology, which, as I said, is different from what we've been listening to earlier. So I'll start by saying that coronavirus is a large family of viruses that get their name from the crown-like spikes on their surfaces, which you can see with electron microscopy. These viruses normally circulate in animals, and some of them also circulate in humans. Rarely you can have a jump of these viruses from animals to human beings. And some of these viruses cause mild symptoms in humans like common cold, and some have been known to cause severe diseases as well. We've had previous outbreaks of this of coronaviruses in the past, in which humans were affected. The first was in 2002 when we had the SARS pandemic, which at the time was also a jump from bats, but there was an intermediate host at the time known as the civet cats, and it affected over 8,000 people in about 29 countries. But fortunately, that was controlled using simple public health measures. And then in 2012, we had another coronavirus disease known as MERS, the Middle Eastern Respiratory Syndrome. And the intermediate host for this then was the dromedary camels. So the current pandemic, which was first noticed in December, was caused by a novel coronavirus because in December, healthcare professionals started noticing individuals with pneumonias of clusters of cases of pneumonias of an unknown cause. And so then this was quite puzzling at the time. And so this was reported to the authorities, and they managed to sequence lung washings from an infected patient. And this was found to be actually a novel coronavirus, which is now known as the SARS-CoV-2 virus, which causes the disease COVID-19. And so since then, as you're aware, and we've heard from the different speakers, many countries have been affected following this outbreak in Wuhan, China, that was associated with a seafood market. This was also known to have, current science suggests that this virus has jumped from bats, but it's still speculative whether there's an intermediate host involved. I know some research articles have mentioned pangolins as being the intermediate host. So in terms of the epidemiology, I'll say the spread of the virus, it spread through droplet transmission and through fomites, that's contact with infected surfaces. And more recently, aerosols are said to be contributory, and the fecal-oral route as well has been mentioned, but predominantly through droplet transmission and fomites. So from the Johns Hopkins University website, shows that as of yesterday, 24th April, 185 countries have been affected worldwide. And we just have just under 2.8 million cases. But today I'm aware it's gone past 2.8, and the total number of deaths reported globally is approaching 200,000. Okay, so globally, the new reported cases by day is starting to plateau, as you can see from the graph there. And similarly as well, the total number of deaths reported globally, new reported deaths by day, is also starting to plateau. But as someone said earlier, different countries are at different phases of this epidemic. So while in general or globally, we are starting to see a plateau, some countries whose epidemic occurred later on are still experiencing an increase in the number of cases reported, while some other countries are starting to experience a decrease in the number of cases and others have plateaued. South Africa, where I'm reporting from, has managed to flatten the curve, but with expansion of testing, which is ramping up and quite robust, we are starting to see an increase in the number of cases, which is a reflection of the success of testing. And I wouldn't say any more about the Indian response because we've heard a lot about it today and its success. I'd like to stop there and take questions if there are any.
Sure.
Thank you.
Thank you so much, Dr. Collins. We'll come back to you after another couple of speakers have, are done with their presentations, asking questions, we'll put them together. So let me now invite Dr. Rajay Narayan, who is a senior cardiologist from St. George's University Hospital, London. He's speaking on disease and its management. Dr. Narayan.
Thank you very much, Dr. Dhanjal, for asking me to speak on this forum. We all know now, because we have been seeing lots of programs especially on the social media about COVID on a daily basis. But just to recapitulate, coronavirus is a severe respiratory condition caused by the SARS-CoV-2 virus, which was initially picked up in Wuhan in China when the outbreak of pneumonia happened last year. We all know that WHO declared it as a pandemic on the 11th of March, 2020. And since then, a lot of people, unfortunately, have lost their lives globally. As far as the clinical manifestation is concerned, because that is what I'm going to talk about, we all know that many of the patients, normally they present with features of fever, dry cough, shortness of breath. But it is also important to realize or know that people can present with other varied conditions, including diarrhea, vomiting, nausea, loss of taste, loss of smell. We have had cases in England at my hospital where people have presented with dizziness and collapse because people get swelling in the brain, which can cause confusion and dehydration. People can also sometimes present with conjunctivitis. But from the heart side of things, people can also have chest pain, because what the virus does is causes inflammation of the heart muscle, which leads to chest pain, leads to heart rhythm disturbances, and sometimes collapse. But the good news is that majority of the people who are infected with corona, they recover very well, because again, 70-80% of these people will have flu-like symptoms and will recover within week, 10 days. But the 20% of the people who get this infection are likely to get complications. And these people are people who have got low immunity with heart disease, diabetes, kidney problems, liver problems, and low immunity. So these people should seek early medical help and come to the hospital, because again, they need to be monitored more closely. And the way we monitor these patients in the hospital is initially keep a very close watch on their oxygen level, because we all know that it affects your lungs. It causes lots of changes at the oxygen saturation level, and hence your oxygen saturation is likely to drop. So we have to keep monitoring their oxygen level very, very closely. And 1/3 of these patients may require further treatment with positive airway pressure and possibly transferring them to intensive care unit where they may require intubation. But the important thing that we need to understand and realize is that till date, there is no treatment for it. There has been so much of talk about hydroxychloroquine and drugs like antivirals, which have been used in AIDS. But unfortunately, most of the drugs that we know of, including hydroxychloroquine, which is again been talked about globally. There was a study which was published only yesterday again, which said that hydroxychloroquine, if at all, causes more harm than benefit in patients with corona. And hence hydroxychloroquine is not indicated as a treatment in COVID. There was also a talk about a drug which we use for heart rhythm disturbances called amiodarone, which again has been proven that it does not, again, help you with COVID treatment. So the most important, I think the important message that is we need to understand, and especially in India, because India has done fantastically well as far as we know still now, but there is a possibility that there may be a peak of cases in India in the coming weeks and months, we don't know. But I think the message is that we have to go by what our respective governments tell us. For example, we have been asked to stay home in England till 3rd of May. In India, I believe it is till 7th of May, and there may be relaxation on the lockdown in a phased manner or some different manner, we don't know. But unless there is a vaccine, which again, we have started doing trials last week at Oxford University in England, and we are hopeful in the coming months, possibly in the next 6-9 months, maybe slightly longer, we will have a vaccine in place, which will be the real answer to this virus. Till then, unfortunately, there is no treatment for COVID. The only treatment that we know of is supportive treatment. And that supportive treatment, as I said, will only be required in 15-20% of these cases. And most important, again, as I said, will be the government in respective countries have to decide what is the best practice in their country based on the scientific advice given by their scientific advisors. And that may be staying at home intermittently, maintaining hygiene, cleanliness, and using the mask if required, as may be the case in some hotspots in the country. So I believe Professor Dwivedi from Australia is going to talk more about the research and the vaccine that we are now going to all looking towards to possibly have it in the coming weeks and months. So I would like to end up there, and hopefully we have an answer in the coming months with a vaccine in place, which would protect us from this virus. Thank you very much.
Thank you, Dr. Rajay. And Dr. Girish, you have already been given a cue by Dr. Rajay to talk about the update on vaccine and drug research. Let me introduce you, Dr. Girish Dwivedi from Harry Perkins Institute of Medical Research from University of Western Australia. Dr. Dwivedi.
Good evening, everyone. I would like to start by thanking the panel and also the SKOCH group, and a very good evening to the rest of the viewers. As Rajay indicated towards the end of his speech, his vaccine is sort of seen as the final answer for this COVID pandemic. I would like to start by saying that, when you develop a vaccine, a normal vaccine development is actually that you can divide that into 3 stages. And we call that 3 phases of vaccine development. In the first phase, once you have a candidate vaccine which is ready, you actually try the safety of a vaccine in around dozen healthy volunteers. So that takes a couple of months. Once you have established the safety of a vaccine, then you go into the second phase, and that's known as a dose-depending phase, or you determine the dose of the vaccine. And then you try that in around 100 participants. And these participants, preferably you would want them to live in a high-risk areas where they're exposed to potential disease. That can take another few months. And then you move on to what is known as phase 3, which is, you try in thousands and thousands of participants. You have a control group, and that means another 3 to 6 months. So a normal vaccine takes 12 to 18 months. Now, because there's so much of research interest in vaccine, last time I looked at this morning, there are 92 vaccine candidates. And as Dr. Naran said, centers in Germany, centers in China, a couple of centers in UK, Oxford and Imperial College, and I think a couple of other centers in United States have already done their phase 1 vaccine. Something very interesting is happening this time, is to bypass the stage 2 and stage 3. We are anticipating a new vaccine development technique, which is known as human challenge studies, which means once you have a ready-made vaccine, you actually inject the vaccine in so-called healthy volunteers, and then you physically infect coronavirus. Yes, and that would mean, if we are successful, this has not been tried. If we are successful, we can reduce that 12 to 18 months time, which I talked about. So what are the vaccine candidates? The virus actually attaches to epithelium or through human body through what we call ACE2 receptors. And there's a specific protein called spike protein on the virus. And most of vaccines are actually directed against this sort of attachment of a spike protein with the ACE2 receptor in the body. The candidates are, so we can do a couple of things to make vaccine. I think there's a big company in China, which what they have done is they have attenuated, which means they have made the virus inactive, is the coronavirus. But if you inject the inactive coronavirus, then you also need some sort of immune booster. So inactivated coronavirus plus immune booster, that's one strategy. UK Oxford group has used adenovirus, which is a virus which can multiply but does not cause infection. This adenovirus is genetically modified so that when it is injected, it produces spike protein and body develops antibodies. The other strong candidate for vaccine is the RNA-based vaccine. Essentially, you use a little genome of the virus and then you sort of coat with things like nanoparticles or with a nanoprotein. You inject. Once it enters the body, it sort of prompts the cells in the body to produce spike protein and we develop antibodies. Or the combination of these one or two techniques. So as I said, there are 92 vaccine candidates. Most are in stage 1. We are trying to bypass stage phase 2 and phase 3, but that needs to be seen. I would add a word of caution here. Is even if we demonstrate that we have a vaccine which is ready, there are lots of other unknown factors which we are unsure, just like everything else with coronavirus. Whilst I would want to be cautiously optimistic that we'll have a vaccine ready, I don't think we will see the end of coronavirus in next few months, even if we have a ready-made vaccine.
Well, thank you so much. So this is quite an insight into it. So we have actually, reached almost the end of the discussion. But yes, it cannot be complete till such time we have certain queries, which are already being raised, are satisfied by the respondents. So Professor N.K. Arora would like to ask a question. So Kunal, can you unmute Professor, please?
Thank you, Gursharan. My question is to Ashish, Rajay, that what is the difference they see in the country response of USA and UK vis-a-vis India? And what are the lessons for India so that we perform better in the coming days? So your own perspective, you are closer to UK and USA response. And can you shed some light on this? Thank you.
Yeah, so I think Professor that's a very interesting question. I think maybe I can answer it this way, that there are two responses. One, the response of the US versus the response of the New York City, because I think they both might have a lot of variation. In terms of New York City, you will be, I would say, testing, and testing. That's one message which has to be consistent. There is no other option other than testing. The second very important aspect is, who do we test? So I know that New York City is working to prepare a team of contact tracers. And this is almost an unprecedented task, where literally what they're hoping is that they would screen every possible scenario of individual which is out there. I suggest that one of the things which I really emphasize is that I think India has done so far very good, but I think the testing has to be increased very, very importantly. Secondly, one thing which might favor India is probably, the report has just come out yesterday, is about the impact of temperature and humidity on the virus. It's if so, I think it depends if the lockdown has to go more than May 3rd, or it's going to get some kind of a break and then again have a spike. Second thing, I would also say that there has to be some benchmark defined. At what time do you define that social isolation needs to exit out? I think those benchmarks should be there. Otherwise, it might become a very, very difficult thing. One of the challenges, lastly, I know I'm taking too much time, but lastly, I would say one of the challenges for the US was that I think the New York took a charge on its own. I would definitely say, as an independent voice here, not as a representation from the CUNY standpoint of view, that the response of the US was late in terms of its implementation of some warnings, early warnings. But I would say definitely that my message is only one: testing and have benchmark for milestones. At what point do you exit out of social isolation? Those have to be very data driven and very, very scientifically approachable to make sure that we are making the right decision.
Thank you.
There is one. Rajya, can you also respond to that?
Yes,
and please
sure.
add in that despite much higher testing both in US and UK, your positivity rate is much higher. We are testing less, as Rakesh told us, 500,000 as of yesterday. But our proportion of positives are much less. Your positive proportion is very high. So there is something else also going on. Over.
Yeah, absolutely. And there are a few things to consider. One, most important thing, that we know that this is a novel coronavirus, so something new, and we don't know how this is going to act and what's going to happen in respective countries. What we can do to prevent is social distancing, and that is where India has done excellent. I mean, because India has started social distancing at very early stage. We were very, very, very late, including America and England have been extremely late in starting social distancing and lockdown. So that was one of the reasons that the virus kept on possibly multiplying in hundreds and thousands. The other important thing to understand when it comes to manpower and resources, although we know that India only spends 2% of the GDP in health, and possibly UK spends more, and we were projecting ourselves that we are better prepared for something like this, although now we can see that whole of our NHS and workforce is struggling with the amount of patients that we are getting on a daily basis. We have now developed, and we have now got one of Europe's biggest ITU setup with 4,000 ITU beds in London alone, and we are building similar hospitals in Manchester, Wales, and Birmingham. When it comes to India, I can tell you that social distancing is the only tool that we have at the moment that has helped us. Because if we allow the virus to multiply in India, if we don't take things seriously, which we are at the moment, and we have to do possibly stage-wise relaxation of lockdown, because again, if we make a lockdown, relax the lockdown straight away, and the virus multiplies and there's a second wave, then things will get out of control, because we don't have enough resources in India, and we all know that. There won't be enough ventilators for all the patients who are going to need ventilators in India. There won't be trained ITU doctors to look after these ventilators, even if you manage to get some ventilators from outside. So I think the most important message is that we have to be very careful, as very staged-wise relaxation of lockdown has to happen. And the only reason I can think of why we have got so many positive cases, in spite of being 1/10 of size of India, is possibly we were very late in our response, and we did not take things seriously. All of February was lost in just thinking about whether it's going to come to UK or not. And that is where one of the learning lessons for us in future.
Kunal, can you unmute Dr. Bhatia, please?
Yeah, thanks, Dr. Rajay and Dr. Joshi for highlighting that. But I think most important aspect is our preparedness. We took the advantage of 40 days lockdown and we followed it religiously, and God knows what we are going for, but we have prepared ourselves learning from all those countries which have suffered. So I think the preparedness is very, very important. Complacency has no role, and we should carry on. According to us, if you ask me point blank, I would definitely advise somebody that it should be extended. Lockdown should be extended for maybe few more days so that we are absolutely sure that the curve is going down rather than just the flattening. So once the curve starts going down, then the staggered approach should be there and the preparedness is there, then we'll be able to control this enemy, invisible enemy.
Thank you. Now, one last interjection from Dr. Collins. Can you unmute him, please? Dr. Collins.
Hi again. Oh, I already typed in something. Just to add to the excellent answer given by Rajay, the UK testing policy is slightly different. The UK is only testing very sick patients, so the positivity ratio is higher as a result. Yeah.
Well, thank you so much. So with this, I now invite Dr. Rakesh Kumar for the concluding remarks, and he would like to say something for India moving forward.
So thank you, Dr. Gursharan and all the participants. I think this was one of the tremendous discussions I've ever participated in this kind of backdrop. But as every participant, very learned, very senior people have spoken and said that India has done tremendously well. There's no doubt about it. And it's all the credit goes to the management, to the government. We are fighting Corona unitedly. I think that is one of the biggest strengths. However, I think we need to be prepared for the worst. God forbid nothing goes wrong, and the climate and whatsoever, whether we are talking about being a BCG country or a country which has been endemic for malaria, like Africa and all. So I don't know what exactly is working. Maybe the temperature now. But I think we should be prepared for the worst because anything can happen. And as Dr. Rajay Narayan mentioned that, we should be prepared for the worst. Because, when you talk about the dynamics of the disease, that it is not different, when we talk about America, UK, US, the virus is the same. The second is, I think in the meantime, we need to ramp up our testing, and especially for the antigen. I think that's absolutely important. It's not only ramping up of the testing, but also about the health system because important part is the training. Dr. Rajay always talks about training of the paramedics and the frontline workers and stuff. If suppose our doctors, they are getting infected in India, like look at in UK and US, doctors are dying because of COVID. The paramedical staff is dying because of COVID. I think in India, God forbid that happens, I think that would be a difficult and precarious situation. Vaccines and drug trials, obviously, I think they're underway. There are hundreds and vaccines and hundreds of drugs are being tried out. But we don't know. I mean, about the vaccines, I don't know. I don't know how to really talk about the vaccines. But look at HIV. It has been more than 35 years. We have not been able to come up with a vaccine. So I'm hoping and praying that we get a good vaccine timely and early. And I'm very optimistic about it. Now, I think one thing we are missing is treatment or the management of the non-COVID patients. In the name of COVID, the country is really worried. How we are managing the non-COVID patients, they're also dying each and every day. So I think we should not lose focus on non-COVID patients, all complicated cases. And I think India should have a kind of strategy. And look at the other vaccination part, we are talking about COVID. Look at, if suppose tomorrow, God forbid, we have breakout for measles, because I think we are not really optimally vaccinating kids. Measles is more infectious than COVID. So I think we should also keep on pushing the vaccination component in the country. That should be one of the emergency interventions, as a part of the emergency response to that. Now look at the stigma of the disease. Again, I think important part, the patients are stigmatized. People are not reaching out. They are not really opening up and saying that I have these kind of symptoms. So that's why people are hiding. And at times people may die. So I think India needs to address the stigma part. I think the Prime Minister has been pushing this agenda from the top and the government is working, but stigma, is going to be a deterrent in the management of these cases. Just two more points, look at the fear psychosis among the doctors and the patients both. Doctors and health caregivers, they are really, they are afraid of, they can catch infections. Every day they are going inside the wards and they are scared of this. Look at the patient, they don't know once they enter whether they'll be able to come back or not, because there's no family contact. And in the worst situations, if they die, even family members are not able to see them. So I think that fear psychosis, we need to bring in those kind of top, psychiatrists and psychologists, to mitigate this problem, this issue. It's not only a medical problem, but medical, psychosocial, I think, problem. It's more complex. We should look at with a bigger lens. Lockdown, yeah, as rightly said, it has worked tremendously well, but I think very rightly Dr. Rajesh said that, and also Dr. Joshi, that, whether India can afford to really ease the lockdown or we need to phase it out, I think that needs to be worked out. But testing will help us decide whether we should take a decision on lockdown. Because if we test and if, let us say, infection rates are lower or positivity rates are lower, then obviously I think the governments can take a decision. But obviously it has to be in a phased manner. Whether you are talking about the railway platforms or airports or the schools or the markets, I think that social distancing norm has to be put in place. And the last point is that obviously the care for the poor, I look at the migrant labor, the poor need to be looked after by this country. Because we have about 40 crore, poor people in the informal sector who are working. And governments are doing tremendously well, from the directions going from the national government to the state governments, the poor have to be looked after in terms of whether we're talking about their food or medicine or anything, till the lockdown is over, because ultimately they're also suffering a lot. I think we all are united in this war. Everybody is standing together. I'm sure we are going to win this war. These are testing times for the world. And for sure, I think this time will also pass away. It's not going to stay forever. But I think we have to find solutions collectively and take it forward. So thank you so much, Dr. Dhanjal and Sameerji, for this wonderful, the seminar and webinar today. Thank you.
Great.
So much.
Thank you so much. It's really been very, very interesting. And in fact, let me seek approval and request each panelist if we can extend the session by a couple of minutes. As I can see a couple of more hands going up. I can see Dr. Bhatia wanting to say something. So Kunal, can you?
I just wanted to thank Mr. Sameer Kochar and Dr. Gursharan for organizing such a wonderful webinar. I think it was done in an absolutely professional time clock-wise, and we are very, very happy to participate. We have learned a lot, and we should carry on having such kind of sessions so that if we are well read, we are seeing the experts from all over the globe, then we are learning, we are able to transmit that knowledge to others. It will be a great victory. Thanks, Mr. Sameer Kochar and Dr. Gursharan and Mr. Kunal. Thank you very much. God bless you.
So thank you so much for the endorsement. In fact, I'm tempted to ask everyone now that as we ran the poll on Aarogya Setu, let me be a little selfish and ask that, let me see the hands going up. How many people actually say yes to our first medical conference that we organized here? So great. So thank you very much, everyone. In fact, the grateful thanks are due to Dr. Rakesh Kumar for helping us, design this conference together, and definitely so Dr. Vidur Jyoti for very closely collaborating with us, putting the the content and giving us deeper insights into what we need to discuss. And all the panelists, ladies and gentlemen, thank you very much. It's been a great day interacting with you all, and a great learning for all of us. So from all the 4 continents, people have joined in. From a great country that India happens to be, a grateful thanks to everyone. Thank you.
Thank you very much. Wish you all well.
Thanks a lot.
Yeah.
Thanks. Good job done.
Right. Thank you. Cheers.